Good morning, class, or afternoon, or evening, or nighttime, or whenever you might be listening to this lecture. This is our lecture on proprioception. So let's start with our objectives. First objective is to display understanding of terms related to proprioception, including agility, balance, coordination, and kinesthetic awareness. Discuss the interaction of agility, balance, and coordination with strength, endurance, and flexibility. Display an understanding of the afferent and efferent receptors and their relationship with the central nervous system, or the CNS. Identify other systems that provide input and how we can affect balance and proprioception through these systems. And then lastly, discuss the importance of neuromuscular re-education and the rehabilitation of the injured athlete. So first, let's talk about proprioception. So proprioception is a conscious and unconscious knowledge of joint position. So I am sitting in a chair right now. I do not have to look and see that my knees are bent to 90 degrees and my hips are bent to 90 degrees, or that my legs are crossed just above my ankles. I can tell, I know where my body is sitting here. So it's the ability to transmit position sense, interpret information, and respond consciously or unconsciously to stimulation with appropriate posture or movement. So as I sit here for a while, I might start getting bleacher butt and have to kind of move around. I don't have to look and see exactly where my backside is coming into contact with this chair to realize or to become aware that I'm getting bleacher butt and need to move around. This is why people who are bedridden and can't move around on their own develop pressure sores, because they don't have that ability to sense where they are and that they need to move or adjust their posture. So the proprioception is an inner sense. It comes from the central nervous system. And let's talk about kinesthetic awareness. So it's an external sense. So this is a body in space and time. So it's a sensation of joint motion or acceleration. So it's a dynamic. Proprioception can be static. I'm sitting here not moving. It can have a sense of dynamic as well. Kinesthetic awareness is that dynamic component to it. So it's a sensation of joint motion or acceleration. My hands may be moving while I'm talking, and I understand and I sense that my hands are talking because of my kinesthetic awareness. So it's a conscious awareness of joint motion, position, and force, which is essential for proper joint function. So for my joints to be able to function properly, for me able to reach out and grab a cup of water and bring it to my mouth, I have to be able to have a conscious awareness of where my hand is in space, bringing my hand towards my face, so I'm just not throwing water on top of my head when I'm trying to get it to my mouth. So skiing is an excellent example of how proprioception and kinesthetic awareness work together. So our bodies require both. We have to have both to be able to move about through our world. So skiing requires the body to reflexively know when and how to coordinate and move the limbs to stay upright. So that's the proprioception part of it. So we need to know that which edge of the ski we're on, so that we can stay upright, so that we don't catch an edge and fall down. At the same time, we also have to know where our body is in relationship to the skis and the slope. So we know that we are aware of which is the downside of the slope, which is the uphill side of the slope, and how our body relates to that. So that dynamic motion of the interaction of our body and the slope is the kinesthetic awareness, knowing that our knees are slightly bent, that we're staying under, or we're keeping our body over our base of support so we're not falling down. That's our proprioception. So they're very similar, but at the same time they're different, and they have to work together in a coordinated fashion so that we can function and move around. So what is neuromuscular control? So here's a pretty complex little picture for you, going from your finger to your brain, and you can follow the red and the blue lines through, beginning at the receptor endings at the tip of your finger. We have afferent fibers, which detect pain and temperature. We have mechanosensory afferent fibers, which then go to the dorsal root of our ganglion cells at the spinal cord level. And then that moves on up to the medulla, which then goes up to the midbrain and our ventral posterior nuclear complex of the thalamus, and then finally to our somatic sensory cortex. I wouldn't get too caught up on this, but to be aware that we have that afferent and efferent, where one is sending information to the brain, and then the brain responds and tells the body what to do. And you realize this moves so fast. So we have the receptor endings. So whenever we touch a hot stove, as soon as we touch it, we're jerking back. We're not standing there waiting like we wait on our computer to process, and we don't have a little hourglass flipping over on top of our head as we're waiting for this to process. This occurs in a split second. It's so fast, and that's what protects us. That's what keeps us from injuring ourselves or burning ourselves, because we can quickly move away from something that may be endangering us. So we got the efferent, our motor, and we got our sensory, the afferent. So the proprioceptors are afferent receptors sending impulses from the skin, the joints, the muscles, and the tendons. So these proprioceptors are basically throughout our body so that we can respond to the environment around us. So we have cutaneous receptors, which are in our skin. They're fast adapting. These type 2 sense vibration. We also have slow adapting, which are type 1 and 3, which are the touch and skin stretching. So these do not really assist proprioception in the uninjured. So you and I, if we're healthy and we're uninjured, then we're not really relying on these cutaneous receptors to give us much proprioception. But in post-injury, they help to take up the slack for damaged joint and ligament receptors. So these start kicking in after an injury to help us to take up the slack for the damaged parts of our body. And then we have the proprioceptive receptors in the muscle and tendons. We have the muscle spindons and the Golgi tendon organs. And I think we talked about those in a prior lecture, how the Golgi tendon organs it's related to speed. The Golgi tendon organs respond to slow stretch and the muscle spindles to fast as a protective mechanism for our muscles and our tendons. They're able to determine joint position because of their muscle length sensitivity. And then we have proprioceptive receptors in our joints. So we have joint receptors, which give us information on joint position. They're located within the connective tissue of the joint capsule and the ligament, and they're divided into fiber groups. We got group 2, 3, and 4. And then we have large and small diameter nerves that are sensitive to compression, extremes of joint positions, and then acceleration and deceleration. We also have nociceptors, which are free nerve endings, A and C fibers. They're located throughout the articular structure. They're stimulated when placed in an end range, and we like to inhibit these by the oscillation or the shake. So if you ever see me doing passive range with anybody on their shoulder, you'll see that I'll take them to end range. So I'm stimulating those nerve endings, A and C fibers, and then I'll back off of the stretch into the passive range, and then I'll shake their arm. So I've activated those A and C fibers by pushing them to the end range of their available range of motion, and then I'm inhibiting those fibers by just shaking their arm. One note for, you're probably wondering about all of these different types of fibers, and that picture that was shown, the afferent, the efferent system going from the finger to the brain. I wouldn't get too caught up in knowing the specifics on these, so I'm probably not going to ask the joint receptors, what groups are they divided into, 2, 3, and 4. You don't need to know specifics on that. I probably would know that the reason that we do the oscillation or the shake is because we're trying to inhibit the A and C fibers. I would know that one. But for the most part, we don't need to get too caught up or too bogged down with exactly which type of receptors. Just understand that we have multiple receptors throughout our body that help to provide our body this proprioceptive awareness. But we always get questions on why do you do the little shake? Why do you shake my arm? Why does that make it feel better? So it's kind of nice to be able to give somebody a little educated answer as to why we're doing that. We're activating the A and C fibers. And then we have different proprioceptor sites. Continuing here, the motor response is determined by the area within the central nervous system that interprets the afferent stimuli. So the spinal cord, so a spinal reflex is the simplest form of reflex or response. Again, that is touching the stove and you immediately go back. It doesn't have to go all the way to the brain. So it makes it to the spinal cord. The spinal cord sends it immediately back to the muscle and says, get your hand off the stove, that's hot. And then we have proprioceptive reflexes that protect area through the muscle splinting or rapid withdrawal. And then reflexes provide joint stability, especially with change of direction. So that's the reason our shoulders, although they're inherently unstable, we have these reflexes when we do make a dynamic change of direction that help us to provide stability. And then the spinal cord moves up to the brainstem at the cerebellum. It's our primary proprioceptive correlation center. Makes automatic adjustment to muscle position and length. Our cerebellum receives input from the eyes and the ears to assist with balance. So that's the reason you have somebody balance on one leg, and eyes open may get too easy for them on a level surface, but as soon as you have them close their eyes, now all of a sudden this activity becomes totally different. We don't always think of the vestibular system, but you can change head position and make a balancing activity more challenging for the athlete. And that's probably something that we don't use enough. And then moving from the cerebellum on up to the cerebral cortex, it is the location of conscious movement, the center of volitional control and movement. So if I reach out to grab a cup of water and bring it to my mouth, that's occurring from the cerebral cortex. So it's got to go farther than the spinal cord for me to reach out and grab something. Now if I grabbed something, if I reached out and that cup was hot, now that spinal cord reflex, the spinal reflex kicks in and I drop the cup because it's hot. I can't overcome that by using my cerebral cortex saying, it's hot, I want to go ahead and keep holding on to this cup. We don't work that way. We automatically drop it. So this is where the input of activity is received. It is the location where correct movement is learned prior to becoming an automatic response, where cognitive awareness is not required. So we have to learn something. Have to learn the movement. So let's say you got somebody that's never played basketball before, and you put a basketball in their hand and you tell them to shoot. They may do a granny shot, they may try to throw it like a football. So we have to teach them the correct mechanics of shooting a basketball. So bending the elbow, extending the wrist, flicking the wrist, extending the elbow. And then once they learn that, they learn the correct movement pattern, then practice over time develops an automatic response where they don't have to think about bending their elbow, keeping their elbow in, extending the wrist, flipping the wrist as they follow through. So then balance. Balance is the ability to maintain equilibrium by controlling the center of gravity over base of support. Like we talked about in our physics lecture and lab, once your center of gravity or your line of gravity falls outside of your base of support, you're most likely going to fall down. That's the reason, going back to the skiing or a skating type of analogy, if we catch an edge, we get too far out of our base of support, then we're going to fall down. So balance is important in both static and dynamic activities. It's really fundamental to most all of the activities. So if you stand up and you cannot maintain your center of gravity and your line of gravity within your base of support, you're going to fall. It's influenced by muscular strength and input from the central nervous system. So you do have to have a certain amount of strength to be able to maintain your center of gravity. If you stand up and you cannot maintain your center of gravity within your base of support, you're going to fall. It's influenced by muscular strength and input from the central nervous system. So you do have to have a certain amount of strength to be able to maintain your position. So you get input from the eyes, ears, and proprioception is crucial to balance. We use our vestibular system, so if you've ever had any issue with your vestibular system, with your inner ear, if you get motion sickness, if you ever been on a boat and you get seasick, or you've been on a boat all day and then you lay in bed and you rock back and forth all night, your vestibular system has just been changed. I don't know if you've ever ridden a roller coaster and you get off and your first few steps seem a little bit wobbly and you seem a little bit shaky. That's why. So the vestibular system sends messages to your central nervous system regarding static, position, and motion. And then you have the vestibular ocular reflex, which allows your eyes to remain steady while your body is in motion. That's the reason that rocking on a boat, you can still maintain your eyes in a steady position even while you're rocking, or if you're standing up and sitting down, you don't get dizzy and you don't lose your train of vision based upon this vestibular ocular reflex. So those two are tied together. And then you have your oculomotor system, where vision provides feedback regarding body position and space. So this works with the vestibular system to determine if you or the environment is moving. So I don't know if you've ever been sitting at a stoplight and suddenly the car next to you starts rolling behind us, so you stomp on the brake a little bit harder to make sure that you're not rolling forward, because that gives you the sense that you are moving forward. So that's how our brain processes that, to determine whether you are moving or it's something in an environment is moving. And then your proprioceptive system, so your balance involves all three of these. And then now let's talk about coordination. Coordination is the combination of appropriate muscular intensity and timing to produce a smooth pattern of activity. So it's a smooth, coordinated motion. So I don't know if you've ever seen an uncoordinated child try to grab something or play with a ball or something like that. It just doesn't look smooth. You reach out and you grab a cup of water, you're not sitting there spilling the water because you're uncoordinated. You bring it smoothly back to your lips, and then you set it back down on the counter, and you haven't spilled anything unless you're uncoordinated. So it's a complex network of neuromuscular activity resulting in muscle activation or inhibition for an accurate response in both timing and intensity. So we see there that muscles may be activated or they may be inhibited for the accurate response to occur. So we have requirements for a coordinated movement. We have activity perception, which is awareness of volitional muscle activity. So we understand what we're doing. It's a cognitive activity. Then we have feedback, which is the ability to adjust movements with repeated activity, which uses the afferent-efferent loop. Repetition causes an activity to become automatic and no longer a conscious process. So back to my example of shooting a basketball, you've got to learn the right mechanics of shooting a basketball. But once you do that enough, you develop what we call an engram, which is a performance that is impressed on the central nervous system through repetition. So you shoot baskets enough, and now it's automatic. You developed an engram. You don't have to think of, okay, I'm 10 feet away from the basket, I need to shoot it this hard, or I need to hit it off the glass because I've got an opponent's hand in my face and he's going to block my shot if I try to shoot it directly at the basket. You have developed an engram so that you automatically can perform the activity because you've done it over and over and over thousands of times. And then, like I mentioned a second ago, that may be muscle activation or it could be inhibition. So you want undesired muscle activity eliminated. And this cannot exactly be just trained out. So you may have a muscle that's jumping in, that's trying to help substitute. Maybe it's due to a weakness. And so we have to, we can't necessarily just train that out. We have to be able, our body naturally inhibits that muscle activity from interfering with the activity that we're trying to perform. Then we have agility, and these all seem very similar, but they are different at the same time, and they all work together so that our athletes can perform at a high level. So agility is to control the direction of a body or segment during rapid movement. So it's a sudden change of direction. So I can run forward and I may not be able to stop very well and cut to my right at a 90-degree angle. So one of our highly skilled athletes can do that very quickly because they have greater agility than I do. So a lot of times it's this agility that takes an athlete from being average to being really good, wherever they can change their direction quickly, they can move quickly, and this is a highly advanced skill. It requires multiple things. You got to have strength, you must have power and speed, you need to have a certain degree of flexibility, and then you got to have balance and coordination. So you got to have a foundation of strength, power, and speed, then advance to balance and coordination in developing your agility. So first balance, then coordination, finally agility. So you can have somebody that is very strong, they're very powerful, but if they're not very balanced, if they don't have a good sense of balance and coordination, then they're not going to be very agile. You could have somebody that is very balanced, but they don't have much strength or power, so their agility is lacking. So you got to have a combination of all of these working together. So balance first, then coordination, and then finally your agility. So we have 4 sensory system functions of muscles. So they have a sensation of passive movement, active movement, a sensation of position, and then a sensation of heaviness and resistance. Whenever we have an injury, we have deafferentiation. There's a big word for you. So this occurs at the ligament and the capsular mechanoreceptors. So it's a damage to microscopic nerves that is associated with peripheral mechanoreceptors. This afferent feedback system is disrupted. This is necessary for reflexive joint stability and neuromuscular coordination. We could have joint inflammation and pain, which increases the sensory deficits. So we have somebody with a big swollen knee, it hurts, it then shuts down the quad. You have that reflex inhibition where now the quadriceps muscle will not fire, it will not work. So we have abnormal muscle activity follows joint injuries due to a disruption of the neural pathways. So joint pathology reduces your mechanical stability, so you may have torn a ligament, which now your knee is less stable or your shoulder is less stable. And then now the capabilities of the dynamic restraint system, which have been inhibited or disrupted by this, results in a functionally unstable joint. So a great example of this would be after a shoulder dislocation. We understand that, especially in younger folks, if you have a shoulder dislocation, you have a pretty high chance of ending up with a shoulder surgery to stabilize the shoulder, because you've damaged the ligaments, you've damaged the capsule of the shoulder, which provides the anterior stability of the shoulder. Maybe even torn the labrum, so you've lost the ability of the chalk block there to keep the humeral head from gliding forward. But most of our stability comes from the dynamic control of the rotator cuff. So once we damage those, and then now the neural pathways have been disrupted, now that inhibits the rotator cuff from doing its job and providing the stability. So now you have an unstable joint and may have repeated subluxation or repeated dislocations as a result. So elements for reestablishing neuromuscular control. First off, we have to have proprioceptive and kinesthetic awareness. So this helps to restore the neurosensory properties. Joint compression helps to stimulate the articular receptors. So that's the reason we like to use closed chain exercises, but we want to use these through the available range of motion where the joint is compressed. So if we take the joint to the far end range on either end, then we have less stability in that joint. Also in this position, we typically have a co-contraction with that closed chain exercise. So now we're getting dynamic stability through the agonist and antagonist on each side of the joint. So some studies have also shown that if you just apply a neoprene sleeve or an ACE wrap, we always think of using those for edema control, but if you'll use those, it helps to stimulate the cutaneous receptors, and it helps to provide additional proprioception and kinesthesia. So then we have dynamic joint stabilization exercises. So this, again, typically you're thinking of a closed chain type of activity where we're getting a co-contraction with the agonist and antagonist. So these are balance and shortening exercises. So we get improved coordination now. So we started off with balance, and now we've moved to some coordinated activities. So maybe now we're making things a little bit more dynamic using a BOSU, a BAPS board, or using single leg stands. Thirdly, we have reactive neuromuscular control, which focuses on stimulating reflex pathways and reactive strategies to unexpected loads. So now this is where we're providing some type of outside force against them, maybe a rhythmic stabilization. Here's a big word for you, perturbation, which basically means that some outside force is acting on your body. So it can be, I can act on them and give them a little shake, a little pressure, a little push. Think of a body blade that vibrates and is now trying to move the joint. You're probably familiar with the old shake weight. That's exactly what that is working off of. So it's imposing disturbances to normal motion, which causes a reflexive stabilization in the joint to occur. And next we have functional activities. And now we're starting to get back to the sport-specific drills. So this is our agility. So this may be we're doing functional tests to see if they're ready to return to their sport activity or practice. And then we have, on this, our objective is to return the athlete to pre-injury status. So you see how we move through that. So we went from, on the previous screen, some balance, and then we went to coordinated activities, and now at the end we're doing agility. So that's the type of progression that we want to have with reestablishing neuromuscular control. So here's some techniques. So if we're talking about lower extremities, we want to go from no weight to weight assisted, and then the closed chain as quickly as we can. We interact with our environment in a closed chain fashion with the lower extremity. It is we're pushing our body away from the earth. Whenever we go from sit to stand, we're not pushing the earth away from our body whenever we go to sit and stand, I guess, unless you're Chuck Norris. He probably pushes the earth away. We advance from stable to unstable, and so I probably need to eliminate this, that going from unstable surface as soon as we're full weight bearing. You really base it on how well the athlete is doing. If they're standing on level ground like the top picture and she looks like she's got that and it looks too easy for her, then yeah, she needs to move down and go down to the blue foam pad. If she's up there struggling and her knees wobbling, then we keep her right there as long as we need to. So then we move from plyos, so we can do some jumping activities. Doing some vertical jumping, some horizontal jumping. I like to do an intermediate with the total gym where I have them jumping off of the mini tramp on the total gym. And then we already talked about the unstable surfaces. We got a BOSU ball, the BAPS board. We can do a ball toss. trampoline hopping. I don't use the trampoline a lot for that, but it's fine to do. And then functional activities. Now we're moving a little bit more coordinated, and we're doing karaoke or figure eight, and then we're advancing up to cutting and sprinting. And then for the upper extremity, so our glenohumeral joint lacks inherent stability from the capsule, like I mentioned a few minutes ago. So we get the stabilization from our rotator cuff. That provides the dynamic stability for our shoulder. So joint stability requires a coordinated muscle activation while complex movements are performed. So what we can do with the upper extremity, again, if you've been in the training room with me, you know that I use the plyo back a lot. So doing overhead plyos, you can advance to throwing, T-band. You can do, again, you want the stability, you want to retrain, so it's not something that you want to do high resistance and low reps with. You want to do pretty high repetitions, but low resistance in doing that. So you don't want to load them up with the gray TheraBand and have them do 5 repetitions. You'd rather stay down at the red or the blue or green and do 25 to 30 repetitions with. And also, if you're wondering, the colors of the TheraBand do matter. So that goes from yellow being the weakest, gray being the strongest. So it goes yellow, red, green, blue, black, gray. So if you have somebody that is weak, you're probably not going to start them on gray. If you got somebody that has fairly good strength, probably the yellow is not going to be enough. And then closed chain, you can do closed chain activities with push-ups or with planks. So you can see the lady on the bottom on the ball. You can see how much dynamic control she must have. So that's a tougher exercise than the one at the top where she's on her elbows doing the plank. And that's our lecture for today. What was your favorite part? In the words of Dora Explorer, that was my favorite part too. Thanks for listening. See you in class.